Welcome to CNU, the video series that will teach you everything you need to know to provide excellent nutrition care. In this video, I'm going to discuss the indications and contraindications for providing enteral nutrition. By the end of the video, you should be able to define enteral nutrition, indications, and contraindications, identify indications for providing enteral nutrition, and identify contraindications for providing enteral nutrition. If you find this information helpful, go ahead and hit that subscribe button. Let's get started. We begin with a review of key terms that are important to understanding the concepts that will be discussed. The first, of course, is enteral nutrition. Enteral nutrition is the process of delivering nutrients directly into the stomach or small intestine. It can also be defined as a method of feeding patients who cannot eat enough to prevent weight loss. It is often referred to as tube feeds or tube feeding because that is how it is achieved, through a tube that bypasses the mouth and the esophagus. Enteral nutrition is not intravenous nutrition or nutrients delivered directly into the bloodstream, and enteral nutrition is not nutrition by mouth, or nutrients obtained through the process of eating. Access for enteral nutrition can be achieved by placing a long tube in the nose or mouth and guiding it down the esophagus. The tube is pushed along until it crosses the esophageal sphincter and enters the stomach. Patients can be fed through the tube here, or the tube can be guided further, passing through the pyloric sphincter and into the small intestine. Once the feeding tube is in position, it can be used as the sole or only source of nutrition, a supplemental or partial source of nutrition, and for fluids and medications. When enteral nutrition is needed long-term, or there is a medical condition that affects the function of the upper gastrointestinal tract, feeding tubes can be placed directly through the abdominal wall and positioned in the stomach or small intestine. The obvious benefit for any means of enteral nutrition is the patient continuing to receive the nutrients he or she needs without having to eat. Our second key term is indication or indications. An indication can be defined as a sign, symptom, or medical condition that leads to the recommendation of a treatment. In other words, an indication is an observation or finding that prompts you to respond in a specific way. When it comes to indications for enteral nutrition, we are talking about anything discovered during the assessment of the patient that leads us to recommend a feeding tube as a treatment. This is the opposite of a contraindication. A contraindication is any sign, symptom, or medical condition that suggests a treatment should not be used. If we think of ourselves as clinicians who always do what is best for the patient, contraindications tell us what we can't or shouldn't do because the treatment may put our patient in danger. So, when it comes to contraindications for enteral nutrition, we are talking about anything discovered during the assessment of the patient that leads us to recommend against a feeding tube. Now that we have defined our key terms, we need to talk about indications for enteral nutrition. In order for enteral nutrition to be indicated, there are two conditions that must be met. First, the patient must be unable to consume enough calories by mouth to maintain body weight. Second, the patient must be able to safely receive nutrients, absorb nutrients, and eliminate waste. Meeting both conditions is essential. If a patient is able to consume enough calories by mouth to maintain body weight, then they are not a good candidate for enteral nutrition. If a patient is unable to consume enough calories, but they also do not have a gastrointestinal tract that can effectively receive nutrients, absorb nutrients, and eliminate waste, then they are certainly not a good candidate for enteral nutrition. In order to receive enteral feeds, a patient must be unable to consume enough calories and have a gastrointestinal tract that is functional. Keep in mind, a patient could still be able to eat something without meeting their calorie needs. A patient does not need to be eating nothing for enteral nutrition to be indicated. At this point, we have established that there are two conditions for enteral nutrition to be indicated, and we have seen how both must be met. The next thing we are going to do is dive a little bit deeper into each condition so you can see exactly how they may play out in the clinical setting. Starting with condition number 1, I have identified patients who are most likely to receive enteral nutrition and separated them into 4 distinct groups. Those groups are the critically ill, patients with neurological disorders, patients with conditions that affect the mechanical function of the gastrointestinal tract, and patients suffering from persistently low appetite as a manifestation of a disease. The first group is the critically ill, who we are most likely to find being treated in an intensive care unit. Due to the severity of their illness, these patients are often unable to maintain many physiological functions on their own. One of the common results of critical illness is respiratory failure with the need for mechanical ventilation, or a ventilator. As you can see with the patient here, there is a tube that is inserted through his mouth and into his lungs to assist with breathing. This is called intubation. In this case, eating is not going to be feasible, and so the use of enteral nutrition with these patients is quite common. The second group includes patients with medical conditions that impact the brain and lead to a decreased level of alertness and a decreased ability or inability to chew and/or swallow. The medical term for difficulty swallowing is dysphagia. At a minimum, these issues will prevent the patient from eating enough calories. At a maximum, it will put them at a high risk for developing pneumonia and/or choking. The most obvious examples in this group are patients who suffer from a stroke or TBI, a traumatic brain injury. The occurrence and severity of chewing or swallowing difficulties depends on the size and location of the injury. Another population in this group are patients with chronic neurologic diseases like Alzheimer's disease, Parkinson's disease, and multiple sclerosis, all of which are progressive diseases, meaning they worsen over time. Finally, we have patients with short-term changes to mental status in response to an infection, drug toxicity, or end-stage liver disease. This is quite common in the elderly, especially when it comes to urinary tract infections. The third group includes patients who are unable to eat because their medical condition has led to mechanical dysfunction. Here, the problem does not originate in the brain. The decreased ability to chew or swallow comes from decreased function of the mouth, esophagus, or stomach. The mechanical issue can come from an obstruction or narrowing, which would be the case with both a malignancy and scar tissue from a condition like gastroesophageal reflux disease, also known as GERD or acid reflux. The mechanical issue can also result from trauma, which might include an otherwise healthy person who fell off their bike and broke their jaw. The fourth and final group includes those with normal chewing and swallowing function, but there are symptoms that reduce the desire or ability to eat. These symptoms are a manifestation of the disease itself or the treatment, and include symptoms like loss of taste and altered taste, which are known as ageusia and dysgeusia respectively. Then we have nausea, vomiting, and fatigue, which can be a major turnoff to food. A common example from this group is patients with cancer, especially those who undergo chemotherapy. Other chronic diseases that can lead to low appetite are end-stage kidney disease and end-stage liver disease. Finally, a few acute illnesses like influenza and pneumonia can result in persistently low appetite and intake. As a bonus, I just want to mention patients with excessive calorie needs and patients with eating disorders. In both of these instances, patients can have normal chewing and swallowing function and a normal appetite, but are unable to consume adequate calories to maintain body weight. For burns and trauma, the calorie demand for healing may be so high that it exceeds what is feasible for the patient to obtain through food alone. For anorexia nervosa and bulimia nervosa, there will be an intense fear of weight gain and a purposeful avoidance of adequate energy intake. So, when we think about our first condition and all of the patients who might meet it, we can look to our categories for clues. In some cases, the need for enteral nutrition is going to be obvious. However, in others, whether or not the patient is a good candidate for enteral nutrition will be much less clear. This is where a thorough assessment of the patient and collaboration with all members of the interdisciplinary treatment team becomes essential. Whenever there is a gray area, some of the most important places to look are the patient's physical appearance, recent weight trend, and estimated calorie intake. Signs of poor nutritional status or malnutrition are as follows. For physical assessment, the patient will have moderate to severe fat and muscle loss to areas like the face, shoulders, clavicle, triceps, and quadriceps. For unintentional weight loss, the patient will have a loss of greater than 5% of body weight in 1 month, greater than 7.5% of body weight in 3 months, greater than 10% of body weight in 6 months, or at least 20% of body weight in 1 year. For estimated calorie intake, the patient will be meeting less than or equal to 50% of estimated calorie needs for greater than 1 week, or less than or equal to 75% of estimated calorie needs for 1 month or longer. Sometimes, we see this written more plainly as inadequate oral intake or an anticipated inadequate oral intake for 7 to 14 days. A patient does not have to satisfy all of the criteria to be considered for enteral nutrition. However, the more criteria he or she meets, the stronger the case to begin it. Another aspect that should always be considered is the projected length of time the patient would need enteral nutrition. Ask yourself, how long is this expected to last? If there is an obvious end to the patient's inability to meet calorie needs, then perhaps enteral nutrition is not needed. Knowing this information will also be useful for determining whether a short-term or long-term feeding tube is pursued. But before we ever get into discussion about the type of feeding tube to be placed, we still need to figure out if enteral nutrition is indicated at all. That brings us to our second condition, which must also be met and states, the patient must be able to safely receive nutrients, absorb nutrients, and eliminate waste. If the first condition is asking, is the patient eating enough? The second condition is asking, does the patient's anatomy and physiology allow for enteral nutrition to be safe and effective? Rather than looking for all of the instances where a patient's anatomy and physiology do support enteral nutrition, we can cover condition number 2 by creating a list of the most common examples of when the anatomy and physiology do not support enteral nutrition. These are the contraindications to enteral nutrition, or any sign, symptom, or medical condition that suggests a treatment should not be used. I have broken contraindications down into 4 categories. They are mechanical and functional obstruction, when food substances cannot pass through because an object is blocking the way or there is a failure of the muscles and nerves. Hemodynamic instability, when a critically ill patient has a significantly decreased ability to distribute blood throughout the body. Severe gastrointestinal bleed, when bleeding occurs in a way that enteral nutrition could exacerbate it or lead to further complications. And severe malabsorption, when the intestines are damaged in a way that makes enteral nutrition ineffective. It is important to note that a contraindication may be short-term or it may be long-term. I will also point out that there may be other instances beyond these selections where enteral nutrition may be contraindicated. These are just the ones I felt were most pertinent to bring forth. The first contraindication we are going to take a closer look at is mechanical obstruction. This is when food substances cannot pass through the gastrointestinal tract because an object is blocking the way. Mechanical obstructions can occur in the esophagus, stomach, small intestine, or large intestine. Common causes of mechanical obstruction include malignancy, such as esophageal cancer, gastric cancer, and colon cancer, adhesions, or scar tissue, which can occur from past surgeries or trauma to the gastrointestinal tract, a foreign body, such as when someone swallows something or inserts an object deep into their rectum, and a hernia, which occurs when a part of the intestine breaks through the abdominal wall and gets pinched. Obstruction of the esophagus and stomach can be bypassed by placing a feeding tube through the abdominal wall and positioning the end in the small intestine. So, you still have an opportunity to give enteral nutrition before the issue is resolved. This is not the same for obstruction of the small intestine and large intestine. An obstruction of the small intestine or large intestine will prevent the use of enteral nutrition until it is resolved. In some instances, this will require surgical intervention. In others, the doctors will give the intestines time to rest to see if the obstruction resolves on its own. Attached to the first contraindication is functional obstruction. This is when food substances cannot pass through the gastrointestinal tract because there is a failure of the muscles and nerves. In other words, food stops passing through in the absence of a mechanical obstruction. Common causes of functional obstruction include abdominal surgery where the intestine is handled, manipulated, or aggravated in some way, electrolyte imbalance, such as low potassium or high calcium, because of the role they place in muscle signaling and muscle contraction, pain medication, especially opioids and anesthetics, and neurologic disease, like Parkinson's disease. Two key takeaways from here are: a common functional obstruction that occurs after surgery is the postoperative ileus. This is quite common in a hospital. Bowel perforation, or a hole in the intestine, can result from providing enteral nutrition before any bowel obstruction is resolved. This is a life-threatening consequence and one that should be avoided at all costs. Next, we move into a concept called hemodynamic instability. There is some debate about how this should be defined or if it is a term that should be used at all, but most clinicians understand it as a delicate situation where a patient has a significantly decreased ability to distribute blood throughout the body. We can come to understand this concept directly from the name. Hemo is the prefix for blood, and anytime we are talking about dynamics, we are considering forces, such as the dynamics between a group of individuals. The cardinal sign of hemodynamic instability is hypotension, or low blood pressure, which is very serious. Hemodynamic instability can lead to multi-organ failure and death. The key takeaway for this contraindication is that enteral nutrition should be withheld when a patient is hypotensive and unstable. Enteral nutrition can be initiated slowly once the patient is stabilized, and this should always be done under the direction of a critical care physician. Then we have severe gastrointestinal bleed. This is when bleeding occurs in a way that enteral nutrition could exacerbate it or lead to further complications. Two common causes of severe bleeds that prevent the use of enteral nutrition are peptic ulcer disease and esophageal varices, which are abnormal, enlarged veins that can occur with end-stage liver disease. I should also note that severe is specified since enteral nutrition can be used with a mild GI bleed without risk of worsening the condition. In fact, with a mild GI bleed, enteral nutrition should be given as it may assist in the healing process. The determination of what is mild and what is severe should be left up to the medical team, not the registered dietitian on his or her own. Finally, we have severe malabsorption. This is when the intestines are damaged in a way that makes enteral nutrition ineffective and possibly unsafe. We may see this labeled as intestinal failure or short bowel syndrome. This often results from a surgical resection of the small intestine. When this happens, attempting to feed the patient using enteral nutrition can lead to severe diarrhea and severe dehydration. Patients can also develop uncomfortable symptoms like cramping and bloating. An example of a condition that can lead to severe malabsorption is Crohn's disease. Before we finish up, I want to cover one more population, those with advanced dementia and those with terminal illness. These patients fall into a unique category when looking at indications and contraindications due to the nature of their disease. On the one hand, a patient with advanced dementia or a terminal illness may appear to be a good candidate for enteral nutrition due to his or her decreased ability to consume enough calories through food. On the other hand, with these conditions, aggressive medical and nutritional interventions will not only have little impact on the eventual outcome, which is death, but may also contribute to further pain and suffering. For this reason, enteral nutrition may be avoided. A careful review of the potential risk and benefits should always be performed with the patient before a decision is made. If the patient is unable to make medical decisions on his or her own, the healthcare proxy, which is usually a family member or friend, should be involved. Here is a summary for this lesson. When it comes to enteral nutrition being an intervention that is indicated, there are two conditions that must be met. First, the patient must be unable to consume enough calories by mouth to maintain body weight. There are 4 groups of patients who most often satisfy this criteria. They are the critically ill, patients with neurological disorders, patients with mechanical dysfunction, and patients with normal chewing and swallowing function but poor appetite due to symptoms of a disease. As a bonus, we can also consider patients with excessive calorie needs and patients with eating disorders. If it is not abundantly clear that a patient requires enteral nutrition, further investigation should go into the physical assessment, unintentional weight loss, and estimated calorie intake. Once a patient satisfies the first condition, we turn our eyes to the second condition. Here, a patient must be able to safely receive nutrients, absorb nutrients, and eliminate waste. Within the second condition, we consider possible contraindications such as mechanical and functional obstruction, hemodynamic instability, severe gastrointestinal bleed, and severe malabsorption. As a bonus for the second condition, enteral nutrition may also be contraindicated in patients with advanced dementia and terminal disease, as it may prolong life but not add to the quality of it and may contribute to pain and suffering. Thank you for watching. Check out these videos for more content just like this.